Good morning again. This is Dr. Bill Wyatt and with the American Orthodontic Society, and I'm going to talk a little bit this morning about advancing the mandible in different people. We had a kind of a fad several years back of using bionators, or sometimes they would just put some acrylic block in there that held the jaw forward. Anything that holds the jaw forward, you're propulsing it out there. We need to talk about it, kind of understanding what it is. We don't make the mandible grow at all. It just repositions it. So let's go ahead here and try to understand some of these things about it. And this is all involved in temporomandibular joint problems that we have, and how we advance the mandible to pull the head of the condyle away from the retrodiscal tissue where somebody's having terrific pain with the irritated retrodiscal tissue, where so much vascular material there producing the fluid, that operates the jaw joint. It has to feed it and lubricate it. So let's get on with it here. This all ties together, though, and you need to kind of have some understanding of that. Here is this young man that we're going to show a few things about. It's just a nice-looking young child, and it's just very nice. His upper lip protrudes a little bit further out than the lower one, and would be better if he could pull that back in a little. So we look at it. Let me see, going back here now. Here it looks perfectly normal, looking straight on. You don't see it back there. But then when he smiles, you see the teeth protruding out like this. And so you wonder, why does this happen? Why do we have so many deep bites and teeth pushed out like this? And I have some ideas about why this happens to start with. And let's go ahead now and look at his teeth. And so the upper teeth are protruding out past the lower teeth, and with the depth of the bite is more than we want. We would like for these teeth to be up somewhere like this, where the lower teeth were just below the upper teeth. In other words, you want a little bit of overjet and overbite, so that when you bite your jaw forward to bite a sandwich, you open it up and bite my front teeth together, and your back teeth don't hit. That's what you want. And when you go from one side to the other, the condyle comes down out of the fossa up here on the right side. When I bite on the left over here, very same thing over on the right. And it shouldn't hit over here when I'm biting over on this side. And that's just the way the jaw is made up to work. And we need to keep it that way and work with it that way. Now, we've got so many people with deep bites. The bite closes down over the lower teeth, and it gets started, and it just comes down there. We don't eat like people used to. I mean, in primitive people, they gnawed bones, they chewed on the hide of animals, they did all sorts of things with them, and I bet you wouldn't find a deep bite in anybody. It's just almost nobody. So my idea is leave the child alone and let him gnaw a few chicken bones, if that helps. That's maybe not etiquette, but it's the best thing. If you eat out here and bite on things, you'll stop this over projection of these teeth. You'll bring the lower jaw forward to bring them to, and you bite on these teeth, and you won't get this deep bite. I really believe that this is one of the reasons we have so many deep bites, and once it gets deep down here, then the jaw can't come forward. And a lot of times as they grow older, the mandible grows and it pushes the teeth up against that, and that pushes the head of the condyle back into the retrodiscal tissue and puts too much pressure on it, and this real vascular tissue becomes irritated and it's sore, and we still have to chew on it, and we chew about it every time you swallow. So it all kind of ties together here, and that's what I want people to understand, what causes it and what you can do to keep it from happening. Now, I really believe that you let somebody alone and let them chew and gnaw with their front teeth, that we wouldn't have the deep bites that we have. So that's just my idea. All right, here this young man has a deep bite, and he's got a slight class 2 problem, not very much. You know, the teeth are up there, so we're going to put him in a binator. Everybody was put binators to advance the mandible out here, and it does advance the mandible. And we thought for a while that we were making the mandible grow. We pull it out there and they grow bigger and everything. So we put Herbst appliances and all sorts of things in there and pull it out there, and sure enough, I chewed out there. But if you took the thing away from them, somebody up in Canada, I think they did a long, big study on it, and they put them in 2 or 3 months, the jaw's closing up there in the front, you take the thing away, leave them alone, and it goes back like it was. Now, we finally figured out, somebody smart enough to figure out what was taking place in here. All right, here's this young man. You can see that these are deciduous teeth, but the permanent teeth are just a little bit behind. The lower needs to be out in this area. See, like that for a good class 1 relationship. And if you advance this mandible out to about here, it would be in that position right there. So let's erase that, and we'll go on. Looking at it from the top, you don't see anything wrong. These are deciduous second molars, first molar, and that's the deciduous cuspid there, which has already gone over here, and the permanent cuspid's coming in. It's kind of getting on top of this root of this lateral, and it's causing it to go back like that. That's not any big deal for us. We'll show that some on the x-ray in a few minutes. Let's go ahead and advance this. The lower anterior now is more, it's distal. It's staying back in this area pretty good, better than the upper anterior. It's kind of flared out on it. Now, if he were biting this jaw out forward and gnawing something or cutting, doing a lot of chewing with his front teeth, this probably would not happen like it is anyway. I'm all for if a child nurses till they're 2 or 3 years old, it is very good for the position of the teeth, and I don't think there's anything that substitutes the real nursing of the child. But anyway, that's something the whole world is facing here. Excuse me. Now, we put a binator in. I don't even show the binator, but all it is some acrylic in there with a few wires holding it in place, and it keeps these teeth up here. It bars this off, and you have to bring your jaw forward on a ramp kind of thing. It's on the binator. You can split them down the middle and crank them apart and spread out the maxilla if you want to. If you've got a child that's breathing through the mouth more, and the upper needs expansion more than the lower one, you can do some of that with a binator. But anyway, we built those things. I don't use them anymore. I haven't put a binate in anybody's mouth for years, and the different things that we used to propose these jaws. But we did a lot of advancement of the mandibles to take care of TMJ problems where the condyle was pressing on this retrodiscal tissue back here. We advanced the mandible where it would close forward, and the condyle didn't hit that, and they didn't have any problem with that. And regardless of how we advanced them, it didn't seem to bother anything about them. It just solved our problem. So we advanced a lot of mandibles doing that. But we did not think we were growing the mandible. We were just repositioning the mandible. Now we go ahead to the binator, and it's just something that aggravates the kid. But he brings his jaw forward, and you can widen the maxilla out, where if he's a mouth breather, the maxilla doesn't widen out properly, and so we would have a problem there. So we put these, binator did have a good point there, expanding the mandible. All right, here it is coming along, and I'm going to show you come to the lower teeth. Now just fit into that. It advances them out, and they tilt forward a lot. Let's look at the cephalometrics on it. We're expanding this. You see, I'm somewhere in there. I've got the cephalometric pictures. Okay, here we go. Now this is before we put the binator in. The lower anterior really looked better, and the upper anterior is laying out here in a point like this. Now once you get this corrected, you come back and fix it. Then you've got to straighten you've got to work on the torque on these upper anteriors, where you bring the root structure forward and bring this back and give them just a little bit of overjet and overbite to fix the teeth upright, where they can bite to the right and the left, or bite with the front teeth out here and the back teeth don't hit. You go in and straighten all that out after you get through with your binator. So it was something that just kind of helped a little bit. Now we come in and bond something on these molar teeth and come out and put a class 2 elastics on it and correct the class 2 problem while the kid is growing, and then it works all right too, the same way. Now, okay, let's look at after he was in the binator. Now, look where the 6-year molar is here, and it's related to this 6-year molar here. But these teeth look like they're dumped way out, and these are too, and that's further than you want them. But if we go back and peek at the binator, the cephalometric end, you see the 6-year molars were just about right over one another in this particular deal. And now we put the binator in, and we bring that 6-year molar to go. This back side is going to come way up here somewhere, where it'll be fitting like that. Now, you can look at this here, and you see where it is. And then, in addition to that, this is tilted way out. Now, for a while there, we thought, well, we're making mandibles grow. You put a appliance in there. The Herbst appliance was a good one. To example, you could wear them for 2 or 3 months, and your jaw would be out there in front. And if you put it on pretty early and then you took it off again, it would go back where it was. Well, what happened in here, this gonial angle, it was coming down, and like this, it would straighten that angle out, and it'd have less degrees, and that would allow the jaw, the chin, to come out this way. And the condyle up here would go back in this fashion, and onwards the condyle would lean back, which put the jaw further forward, and this angle on the jaw down here would get bigger. In other words, it would straighten out, so the jaw that would lean back here now would be out front. And this kind of fooled people for a little while. We ran around thinking we were making somebody grow a jaw, and then you take it off and it would go back like it was. Well, that stayed the same, but we did so much jaw advancement on people working on their temporomandibular joint up here where the condyle was pressing on this retrodiscal tissue and causing a problem, and we advanced the mandible out here just to get the condyle off of that, and we finally learned how to hold it. If you kept it out there with a ramped appliance for a long enough time, then the teeth would, the interdigitation of the teeth would hold the jaw out there. See, the lower teeth would fit in a little socket in here. And that was why they learned that Herbst appliances didn't work well unless you put them in and you take them out after they get their permanent teeth in. And once the permanent teeth come in, you've got the interdigitation. It's nothing like that, of course. It's something like this, where the tooth would be up there and the other tooth would fit up in this, like that. And just biting together, the bottom teeth would be held forward by the upper teeth. If there was any change in here, and every time they chew, it slides down into that socket, and then the Herbst appliance tend to stay, and the jaws tended to stay in that forward position. And we've advanced the mandible of so many people working on their jaw joint back here, till we just started doing it and making them look better. You know, you advance somebody's mandible. We had no problem with any problem with advancing the mandible. But if it goes back, you have problems. So let's go ahead and let me see what we got left here on this. And here are the teeth coming in, and there's always other problems that develop. And this is a problem I want to point out where we're there. We got a good mesial root, see, on that tooth. But this one right here is going away. And this bicuspid will come up in here a lot of times and just set. It'll come up and kind of set in this area. And this piece of this root will hold this, and the advancing tooth cannot dissolve the enamel structure of the deciduous tooth, but it can eat the whole part of the whole, the dentinal part out. The same thing is happening in this one. Now this tooth is coming forward, but it's kind of leaving a sliver of tooth back here, and this may hold this tooth down and prevent the eruption of this bicuspid for a long time. Sometimes it'll take it a while, and then it'll eat this off, and then it'll come on up in there. And when I was in dental school, they had me go in, there was a root down in here, and dig around in there and mess up somebody's mouth to try to find that root. If I'd just left it alone, the body would have resorbed it. And I've got several cases showing where you had a piece of root in here and you came up and it would eat it off after the tooth came in here, or just the little cells in there that pick up and eat the dentin structure and the root, but they don't mess with the enamel at all. So that's another point you get in here. And you can see how far the upper came down, the lower came up here. And if this child had been gnawing on bones like primitive kids did, I'll almost guarantee you that there wouldn't be the deep bites that we have today. And the deep bites come in, and then later on when the jaw takes a forward growth in men especially, or from anything, that makes the jaw go back some. And if the the joint is one is tender and ready to go, I mean, you have a problem, then they'll have TMJ problems. And I think that's on some of the development of mankind that's causing it. And this is my own idea. I don't think it, I don't have any basis for it other than just looking at those Indian skulls out in San Angelo at Fort Concho, where there wasn't any deep bites in those people. So I think we're about at the end of this. But these teeth are erupting in, and we would come back and finish this case up like that. I don't have any finished things on the kid, but we're just got him pretty well lined up, and they'll get the last baby tooth in there. Now, we saw those roots, so sometimes you would flip those teeth out or get them out of the way if a root was holding on the mesial or the distal of the second deciduous molar back there. And these will come out, and then the tongue pushes them over, the cheeks catch them on one side, pull them back, and the only thing you have to have is a rotation of the teeth. So I'm going to, I think that's about the end of our video. Okay, here this has come in, and we've got them in a good class 1 relationship, and we've finished the case up. And I hope you picked up something, but this advancing the mandible causes the lower front teeth to tilt out a little bit. It also straightens this gonial angle out, and it moves the head of the condyle back like this. And if you do this and you've got good interdigitation of the teeth hold the teeth in that position to some extent. And if they're not, they're flat, they don't work. It doesn't work good on the deciduous teeth. They don't have enough cusp on the teeth. So this is something that's very helpful in doing your orthodontics. I thank you for watching, and we'll go ahead and finish this guy out. But I don't have his finished pictures, but this is the way we would work up, and the way we did for a while there. I never did use many of these binators, but they help some. So thanks for watching, and hope you'll join our group and subscribe to our channel, and we'd like to have you, and we'll just keep on trying to explain different things about orthodontics